Hello, friends, and welcome back to this steer case discussion series. As you know, we are presently doing CNS case discussions. Today, we are on case 27, and today our discussants are Dr. Amdekar sir and Dr. Tushar Maniar. So, over to Dr. Tushar for case 27.
Thank you, Dr. Rajesh, and good evening, sir. We start with case number 27 today, and the history given to us is a 6-month-old infant presented with inability to hold the head. Born at 32 weeks of gestation, normal delivery, did not cry at birth, required tactile stimulation and oxygen support, and the child settled over next 24 hours. The birth weight of the child was 1.7 kilos, length being 43 centimeters, and head circumference being 32 centimeters. So, what more information do you think we should be taking from the mother?
Yes, I think the main complaint is inability to hold the head, and the baby is 6 months old. So we need to get far more information. First, about the present complaint. That is this a single symptom or is associated with many other changes in tone or power, cognition, and in general, all the milestones? So we must first confirm whether we are looking at an isolated problem or really a part of the global development problem. Going back then, we know that this was a preterm, which needed a very minimal resuscitation. So that should not have caused much of a problem, and therefore that possibly was just a transient requirement, and the child settled quickly. Now, of course, the best way is to find out uh, how was the cry at birth, how was the behavior at birth, where did the baby put on the breast, sucking well. All those details will convince us that there is no neonatal encephalopathy. Once we confirm that, then of course we like to know the details of milestones almost every 4 weeks till the age of 6 months now. With all those details, I feel we will be able to reasonably consider where is the anatomy of the problem. Certainly looks neurological, but at this point of time, with little more information, we can possibly decide whether it's the central nervous system or the peripheral nervous system, and then, of course, go deep into the probable cause. Do you agree, Tushar, or you want to add something more?
Sir, absolutely. One more thing would be though mother has not volunteered the large head, but because the baby has been preterm, if there is some reason by which the head size is increasing, and then that was one of the reasons for not holding the head was also be like more like a physical problem would also have to be ruled out since we don't have a clear history of neonatal encephalopathy. So looking at what information further we got was that when the child was started on breastfeeds and whether he was feeding well or not and whether he was moving all four limbs, what was the posture, swallowing, breathing, turning over, and other domains of milestones, as well as the head size and any other defects or abnormalities or any other complaints that the mother has had. That is what we would be looking for. So looking at the actual history, the mother tried to breastfeed, but the suck was poor, and so the child had to be spoon fed. And child was a fussy feeder, was not able to feed properly. Head size appears to be normal as far as the mother is concerned. Child is moving all four limbs, though mother is saying that she has noticed flabby muscles, and other domains seems to be normal. So how do we analyze and make a clinical probable diagnosis? Huh?
I think we are reasonably sure that the problem of some weakness has started pretty early in life in terms of poor suck. And the rest of the things look all right. So the baby is not kind of suppressed or depressed because of the any issue postnatally. And to that extent, looks more of a peripheral problem. But this peripheral problem is not involved as such many other muscles. For example, swallowing looks to be possibly or sucking certainly is deficient. And we have also heard about the child not holding the neck. So other domains other than gross matter possibly are normal. And the mother has also noticed that the muscles are loose or flabby, and therefore looks like it's a floppy baby, whatever the cause of this floppy baby is. But something that has started or noticed right at birth, and therefore this must be a congenital problem rather than acquired postnatally. And to that extent, we know that this is a congenital problem, and we would like to kind of see what's happening further on this child. Uh, so far, except those few muscles around the face and the head and neck, we haven't had anything more. So the question is, are we dealing with some localized problem of a muscle involvement, or whether it's a part of a general muscle involvement? I think we will have to see how the trial goes further. What
Yeah,
would be your
Rajesh.
comments on all that?
Rajesh wants to say something. Yes, Rajesh.
I just wanted to re-emphasize that for students, superficially it looked like the baby did not cry at birth and needed resuscitation. So one might wonder whether this is just hypoxia and brain damage at the time of birth. But you have to notice the disparity, as Sir pointed out. So the amount of resuscitation needed was negligible, and yet the delay seems to be profound, as in not head holding even at 6 months of age. Further, for such a severe degree of asphyxia, there would have been seizures in the immediate neonatal period, difficult means refusal to feed, etc. So that was one part. Now, one could also think of chromosomal disorders as a etiology of both the prematurity itself and the not crying at birth and then subsequent delayed milestones. So one should look for dysmorphic features or etc. also for history and on examination. And again, this difficulty in feeding or swallowing, one might take it as a kind of a bulbar or a pseudobulbar palsy that is associated with cerebral palsy kids. But as we have already pointed out, there is a disparity. So we are not really dealing with hypoxia at birth, but we are dealing with something else. Yes, sir,
Also,
Amdekar, sir.
yes, sir.
Hmm. I think, Rajesh, I would say that any chromosomal abnormalities are less likely because you have a specific problem of a poor and I think that's little unusual. Well, just not holding the head and neck could be a part of generalized hypotonia, like even a Downs have. But possibly, even a Downs with generalized hypotonia, this kind of a complaint doesn't come forth so much as possibly a little delay in all domains. So, to that extent, you have made the right point that we need to look at a floppy baby as also a syndromic, but this baby looks to be floppy and also possibly a muscle weakness. Put together that makes it very much a neurological and peripheral neurological disorder. Tushar, your
Also,
comment?
yes, sir. So also to remember for students especially is that when you see this kind of a child with hypotonia, a very young infant, you generally tend to dissect them into whether it's a central or peripheral involvement. And that's, as sir said, this is more peripheral involvement. Also, we should remember though the child is 32 weeker and preterm, that cannot be used as a excuse or a reason for delayed head size, saying that we are going to give allowance for the prematurity of 4 weeks into adding into the milestone development. And though premature babies sometimes appear to be flabby and soft, they definitely don't have problem in sucking and other muscle weaknesses that has been noticed. So going
Sure.
further,
What about SMA,
right.
spinal
So I
muscular
was going
atrophy?
to address it a little later, but SMA is a very good thought. The only challenge here is that there are two types of SMA that we can consider here, either SMA 0 or SMA 1. SMA 0 would have presented much more aggressively, and SMA 1 would not have been normal. I mean, I would be in this condition at 6 months. So we are that way somewhere in between. Also, as Amdekar sir pointed out, these symptoms are from right from day one, and usually SMA is a ongoing degeneration, and hence the sucking and other complaints come a little later compared to present at birth, unless you are dealing with SMA 0. Sir, your comments.
Oh, I think that's perfect. I agree fully with you.
So going further, this child was advised physiotherapy and asked to report back at the time much earlier, but was lost to follow up, and was brought back at 3 months for inability to, sorry, brought back at 3 years for inability to walk without support. So this child, just to recap, 6 month old, we were seen the first time with this inability to hold head and poor sucking, did not follow up till 3 years, and now at 3 years has inability to walk without support. So how do we now narrow down or advise further?
I think on the face of it, it may look like a progressive disorder. But we need to know a lot more about what happened between 6 months and now when the baby has come after a long period. Uh, Obviously, when the story is not able to stand or walk without support, the power doesn't look to be too bad. It's grade 3 plus, and therefore, in the right sense, this doesn't look like a very progressive disorder. Therefore, there are two possibilities in my mind. One, whether a minor weakness in the limbs was missed in the initial part of the history, because the baby was 6 months old at that time. And with power not so bad, the child could have been moving the limbs reasonably well for the mother to feel that there is nothing wrong with the limbs. And to that extent, it is possible that this story of weakness in the limbs has maybe minimally started way back or soon thereafter. And because it was very minimal, it was easily overlooked. So, in that case, it really doesn't look like a progressive disorder. Uh, the progress seems to be very slow or negligible. Now, any progressive disorder at this age, like we discussed earlier, SMA, etc., would have just gone on very fast and to that extent, the question is this is very likely non progressive. But we need to confirm that. Then another issue is that there could be many other defects along with it, because after all, if there is some congenital uh, peripheral problem, there could be some more, or the problems resulting out of weakness. And therefore, we need to keep in mind how does this whole look like on further examination. Confirm, of course, that all other domains are fine and there is nothing much wrong with the higher centers. And then we certainly put down to uh, either a very slowly progressive disorder or totally a non-progressive disorder. And I'm sure the examination can possibly find out the difference. Uh, so we stay with the peripheral neurological system, neuromuscular, unlikely anterior cell, unlikely any other part other than muscle. So we've come down to say it's a congenital muscle disorder. But most of these myopathies are often non-progressive. This looks like possibly even a small way, very slowly progressive. But I'm sure myopathies are of different types, and generally, though static, some of them may be a very mildly progressive. And we know that CP sometimes uh, looks progressive, even if it is static, because some contractures developing or whatever. And therefore, I think at this point of time, we will zero down to possibly a neuromuscular problem, neurological muscle problem, so we'll call it myopathy. Your take on all this, Tushar?
I absolutely agree. And just looking at the history once again, he held head at 7 months, turned over at 12, started sitting at 18, started standing at 26 months. So his DQ has not been going down very fast. The ratio, the development quotient is not changed drastically, though it appears that he is still not gaining new steps. and that is classic with either static or a very slow progressive disorder. But also there is suggestion of swallowing difficulty, choking, fast breathing, the cry being poor, and some respiratory infection. So this looks like probably a muscle which has skeletal muscle, peripheral skeletal muscles as well as respiratory muscles involvement together.
I think
So sir,
agreed. Now, Tushar, you just tell us now what kind of examination findings would you anticipate with our discussion so far?
yes sir. So because this child has had feeding difficulty from day one and was having poor suck, had to be given at outside feed, etc. And now is having, even now is having difficulty in feeding and respiratory infection, etc. I expect the growth to be on the lower side. There will be generalized hypotonia. And as we were discussing earlier, it would be a peripheral type of hypotonia. So severe hypotonia with depressed or maybe even non-elicitable reflexes. The and cranial nerves generally would be normal, but the respiratory excursions could be poor. There will be tachypnea rather than distress. And as you rightly said, sir, probable contractures, etc., may be present. Dependent reflexes would be depressed or absent, and plantars will usually not be affected. That is what my assessment is.
Absolutely. I want to give you one more thought that because this child has been not very mobile or restricted mobile, uh, do you think that small other domains could be falsely affected to a small extent? Like this child is unlikely to have a good social interaction opportunities to kind of progress on cognitive functions or maybe even language, etc. So you agree that a milder variation in the other domain should not worry us and still possibly say that it is all due to the peripheral lesion itself.
Yes, sir. Exactly opposite of what we normally say for autism spectrum disorder. That primary language and speech will be affected, but you can have some amount of motor delay. Similarly, here, other way around, major gross motor, fine motor to slightly lower extent, but language and cognition just and socials just slightly affected. That too may or may not be affected.
And
So the actual findings on physical examination was there was severe malnutrition, there was generalized hypotonia, deep tendon reflexes were absent, feels pain and touch, mild tachypnea was there, plantar flexion of foot was there, and dynamic contractures at both ankles with high arched palates and elongated face.
And uh, what is your comment on high arch palate? I think it's a very non-specific finding, isn't it? Though possibly elongated face. Would you give a lot of importance to this? After all, there is a lot of variation in human beings. Uh, so, what is your comment on that?
Yes, sir. Otherwise, if not in this particular case, one would not pay too much attention to that. But looking at this primary muscle disorder, they have poor power in the facial muscles, and that's why they can have the classical inverted V signs and elongated face and other things. I don't know exact mechanism why high arch palate develops in children with myopathy, but these are some of the findings which have been kind of described. So your
So, I
comments.
think it looks like that you made a point that because of muscle weakness, there could be some changes in the constitution or figures, and that may or may not be very specifically related. But you made a strong point that because this child has a myopathy, you would even consider those small little abnormalities as relevant to the problem. And I think that's well said. So finally, how would you put up your final diagnosis?
So, sir, I would say that this is a slowly progressive muscle disorder which has no diurnal variation, affecting with hypotonia and depressed, with absent reflexes. So I would say more of congenital myopathy, which type I don't know exactly where to put it, but the other causes of myopathy of floppy baby, like dystrophies, congenital dystrophies, or um, myotonia, etc., does not fit into this picture. So I would say this is a primary muscle disorder with malnutrition, and we'll have to investigate further to come to an exact diagnosis. Rajesh?
Yeah, the signs might have suggested a peripheral nerve involvement also because of the absence of reflexes. Anterior on cell, we already discussed that the amount of weakness is not so much, but you can't have a peripheral nerve involvement everywhere so symmetrical and over such a long time, and that is why this is a muscle disease. So the absence of reflexes have to be interpreted properly by the students.
And also, when you talk about nerve diseases, they hardly ever affect the respiratory muscles and the bulbar muscles. So that definitely puts one away from the nerve, even though, as Rajesh rightly pointed out, the absence of deep tendon reflexes. So let us not go by one particular sign only, but try to put together everything and then make a diagnosis. So,
Suppose there was no history of the poor suck or feeding problem, and the story started only with not holding the head and neck, and the story like little delay in gross motor milestones. Of course, this delay is significant, but uh, what is your comment on a term that is used as congenital hypotonia, which often over time just recovers completely? Uh, any comments on such a disorder, which also looks like a hypotonia generally, but it's not very pathological. It's a delayed development in terms of tone, and most of them catch up very well, especially with little physiotherapy, they become normal. So, any comments on such an issue?
So, sir, one would consider that one when there is no suggestion of neonatal encephalopathy, when the growth and nutrition development has been normal, other milestones have been completely normal, there are no dysmorphism, and except for hypotonia and probably hyperflexibility, other than that, all the other parameters are normal. Also, the delay in the gross motor milestone is like just above normal range, and the gap is not widening. With normal reflexes and no, obviously, no contracture, no cranial respiratory, no other involvement, one would call this as congenital hypotonia. And as we previously we used to call it benign infantile hypotonia, but now we don't use the word benign because that generally puts us on a lesser alert. So that is why we would like to just drop the term benign and keep it as congenital hypotonia. And with physiotherapy and ruling out other treatable causes like rickets, etc., one would be able to come out of this.
Complete. I think uh, looks like overall that this kind of combination would typically of a muscle disorder, but we discussed all the rest of it. Rajesh, would you sum up now the whole story?
Yes, sir. So, friends, today we discussed a 6-month-old infant who presented with inability to hold head. And we had a history that this baby was born 32 weeks premature and needed minimal resuscitation at birth. So, we discussed that upfront it may look like that there was birth asphyxia, but then we discussed that because there is so much disparity, as in there was minimal resuscitation needed, the baby did not have seizures, the baby did not have major difficulty or refusal to feed in the newborn period. So the degree of this asphyxia was not much, and therefore this complaint was not really due to asphyxia at birth. Then we discussed other possibilities like chromosomal disorders, where we said that there would be dysmorphic features the subsequent course, of course, would be different. But here, interestingly, there was one complaint that the baby had difficulty in sucking right from day one. So this complaint, if specifically and properly elicited, suggests a muscle weakness. Now, students, of course, you have to differentiate between different kinds of problems in feeding. So you could have, a baby with some aspirations, or you could have a cardiac baby with suck cycle, but difficulty in sucking is a different complaint, and that would suggest a muscle weakness. Then we realized that the subsequent development of this baby in terms of motor milestones was not bad, as in this baby kept on achieving milestones at a steady pace. So this almost told us that this is a very slowly progressive, if at all, or actually a static disorder. And again, we have already discussed that the birth asphyxia is not possible, because that is the commonest static disorder that comes to mind. So in this case, that was not the reason. So then we try to decide whether it's a central or a peripheral hypotonia. Since there were no other central complaints to go by, we decided this is peripheral uh, floppy baby due to peripheral causes. And once we came down to LMN, we decided that anterior horn cell is not the anatomy, because the progress would have been totally different. The baby would not have achieved all those milestones, and therefore the anatomy was between nerve and muscle. Then we pointed out that nerve disease at such a age and bilaterally symmetrical and all over would, one, it wouldn't, this would not be the course of such a disease. Secondly, as Tushar pointed out, they do not affect the respiratory muscles and the facial muscles and sucking and all that. So therefore we zeroed down on a muscle disease which is probably static or very slowly progressive, and which is right from birth, and therefore we came to a diagnosis of a congenital myopathy possibly. We noticed that because of the feeding difficulties, this baby was quite malnourished on examination, and the signs were all consistent with a lower motor neuron disease. That means hypotonia and absent reflexes. Anything to add, Amdekar sir?
Oh, I think you said it so perfect.
Sure, anything to add?
No, Rajesh, that was
No.
so nice.
So friends, I think we stop this case here. Thank you so much for joining us each time for these case discussions. As you know, the subsequent turn on Tuesday, there is a small solo video on relevant information about the diagnosis that emerged from this case. As you know, we are presently nearing the end of our CNS cases after 2-3 cases, and then we will be starting CVS cases. So please spread the word across to your friends. Please visit our channel, like it, subscribe it, and share it with everyone. Thank you very much. See you
Thank
on
you.
the next video. Thank you.
Thank you so much.
Thank you, Amdekar sir. Thank you, Tushar.
Don't miss the new case discussion series by the Steer team.